what is basically crystal arthropathies, right? What is basically crystal arthropathies? They present with episodic arthritis. They mostly present with episodic arthritis, right? And what actually happens is that there are certain microcrystals of various substances that get super saturated and deposit in the synovium or in the in the areas that is adjacent to the synovium. So they can have very variety of manifestation other than the arthritis, right? So what are the different crystals that can cause arthropathies? They are monosodium urate, which causes gout. Then you have the calcium pyrophosphate, which basically causes the calcium pyrophosphate disease. Then you have the calcium oxalate crystals, and you have the calcium hydroxyapatite crystals, right? So each of them have got its own role, and each of them are capable of causing different type of diseases and depositing, right? And what can be the clinical manifestations? So they can cause episodic arthritis, which can be monoarthritis, oligoarthritis, or even polyarthritis. They can cause surrounding inflammation in the periarticular space, giving rise to bursitis, tendinitis, and enthesitis. They can also get deposited as tophi. They can also get deposited as tophi, right? And ultimately, too much of acute arthritis leading to recurrent attacks can cause chronic destructive arthropathy. So they can have chronic destructive arthropathies. They can also coexist with osteoarthritis, right? They can also coexist with osteoarthritis. And in certain cases, they may also give rise to formation of renal stones. They can also form renal stones. They can also cause spinal arthritis, and they can also cause carpal tunnel syndrome. So keep in mind, whenever you are evaluating a patient of carpal tunnel syndrome, always keep in mind to do a uric acid level also in addition to the other investigations you do. Now, we will start with the most common crystal arthropathies, which is the gout. This is the most common crystal arthropathy, which is the gout. Now, how does it arise? You have a state of hyperuricemia. You have a state of hyperuricemia in your body, which when crosses a certain serum level, right? When crosses a certain serum level of 6.8 milligram per dl. You have to remember this. This is given in Harrison, that which when crosses a serum level of 6.8, there is supersaturation and crystal deposition. This give rise to acute gouty arthritis. This gives rise to acute gouty arthritis. Now, they can have recurrent attacks. They can have recurrent attacks. So, recurrent attacks of acute gouty arthritis ultimately can give rise to chronic arthritis. Ultimately, will become chronic gouty arthritis, right? So, as I mentioned, that there is a state of hyperuricemia, and when it crosses a particular serum level, that is 6.8 milligram per dl, there is supersaturation and crystallization in the joints, and this incites a inflammatory response. It incites a inflammatory response, giving rise to acute gouty arthritis. So there would be certain predisposing factors and certain triggers that would give rise to this hyperuricemia. So let's read that. What are the predisposing factors that give rise to this hyperuricemia? Use of diuretics. There are certain diuretics that can cause hyperuricemia. So they can cause hyperuricemia and ultimately the chain of events that I mentioned. heart failure, hypoxia, obesity, insulin resistance syndrome, insulin resistance syndrome. All these are predisposing factors for hyperuricemia. Along with that, you can have certain triggers. You can have certain triggers, out of which the use of alcohol, a diet that is rich in purines, or you took diuretics, or you took drugs that lower the uric acid level. So all these can precipitate an acute attack of gout, right? Now, coming to the clinical feature of gout. So as I've already mentioned, that the most common presentation is that of episodic arthritis, right? The most common presentation is episodic arthritis. And the most common joint involved, the most common joint involved is the first MTP joint, is the first MTP joint. This condition is known as podagra. This condition is known as podagra, and you can get a joint that is hot, tender, swollen, and painful. So you can get all the features of inflammation, and such is the swelling that you can get confused with cellulitis. That's why this condition is also called as a pseudocellulitis, and it is also called as a pseudocellulitis. और इसका एक particular feature ये भी होता है कि they basically these attacks, they tend to happen mostly at night or early morning, or early morning. So they kind of become an emergency that you have to visit a doctor with such a hot tender joint. Okay. So once the episodic arthritis happens, once the acute arthritis happens, they last for 1 to 2 weeks. They last for 1 to 2 weeks, after which there is a remission, and recurrent attacks can give rise to chronic gouty arthritis. Can give rise to chronic gouty arthritis. Apart from that, you can have tophi deposition, and you can have uric acid stone, and you can have uric acid stone. So all these can be a manifestation of gout, out of which you have to remember this fact that the most important joint, the most important joint that is involved in gout is the first MTP joint. Is the first this joint, metatarsophalangeal joint, that is involved. So first MTP joint is the most important joint that is involved for the podagra. Okay. Now, if you have to diagnose this gout. Now, diagnosis of gout, for a definitive diagnosis of gout, you have to do a synovial fluid analysis. You have to do a synovial fluid analysis. For a definitive diagnosis of gout, you have to do a synovial fluid analysis, and you have to demonstrate the uric acid crystals. And you have to demonstrate the uric acid crystals, which are basically rod shaped. They are rod shaped and show negative birefringence when viewed under a polarizing microscope. So this is important. So if you are viewing the crystals under a polarizing microscope, they will be showing the negative birefringence, right? So you have to, for a definitive diagnosis, you have to do the synovial fluid analysis. This also rules out, this also rules out other conditions like calcium pyrophosphate disease. You also rule out septic arthritis also. So when you do the synovial fluid analysis, when you do the synovial fluid analysis, there is a condition which is gout that we are discussing, and there is a condition known as the pseudo gout. There is a condition known as gout and there is a condition known as pseudo gout. So pseudo gout is due to the deposition of the calcium pyrophosphate, and gout is due to the deposition of the MSU, monosodium urate. Now this condition basically, as you can see in the figure, that there is a rod shaped crystals. These are the rod shaped crystals and they have the negative and they have the negative birefringence. This is when you view under a polarizing microscope. And on the other hand, the pseudo gout, if you can look at the image, you have a rhomboid shaped crystals. You have a rhomboid shaped crystals. You have a rhomboid shaped crystals. They have positive birefringence. They have a positive birefringence. Okay. And so, as I mentioned, the synovial fluid analysis is basically the the diagnostic method of choice. Without the synovial fluid analysis, you cannot diagnose gout. You cannot diagnose gout properly. It is definitely a clinical diagnosis, but if you have to stamp it that this patient is having gout, you have to do a synovial fluid analysis. Okay. So, some of the radiological signs that you can get in patients of gout. If you do a ultrasound, that is a musculoskeletal ultrasound, what you will get is a double contour sign. What you will get is a double contour sign. This is one and this is one. So you get something known as a double contour sign. You get a double contour sign. In surgery, you have read about the double bubble sign. So in medicine, you have to remember something known as a double contour sign. This is the gout. Okay. Coming to the X-ray. Coming to the X-ray part, you get these erosions. You get this erosions, and you get these erosions with the overhanging edges. You get these erosions with overhanging edges. So see the erosions with overhanging edges. So these are the classical radiological features of gout. Okay. Now, what will you do for treatment? What will you do for treatment? So treatment we can divide as acute treatment and the preventive treatment, right? So what will you do for the acute attack of gout? Remember one thing, never lower the serum urate levels in acute attack of gout, which means you will not give any preventive therapies to a patient of acute attack of gout. Second point, serum uric acid levels may be normal during the acute attack. Okay. So serum uric acid levels, they may be normal during the acute attack. So what you can use for acute treatment? You can give NSAIDs. You can give NSAIDs. Any NSAID which you like, you can give. You can give naproxen. You can give endomethacin. Any NSAID you can give. And its full anti-inflammatory dose has to be given. Other drugs, colchicine. Next, glucocorticoids. Next, glucocorticoids. Sixth, anakinra. So these are the drugs that you can give for the acute treatment of gout. Next, we come to the preventive treatment. Next, we come to the preventive treatment. In preventive treatment, you can have a xanthine oxidase inhibitor. You can have xanthine oxidase inhibitors, or you can give a uricosuric drug. These drugs increase the uric acid excretion via urine, right? Or you can give uricase, or you can give uricase, right? So we will first start with xanthine oxidase inhibitor. Now, the most important drug that you give for the preventive therapy of gout is allopurinol. So this is the most common drug that is given for the preventive treatment. Now, you have to remember certain contraindications. You have to remember certain contraindications. It cannot be used in CKD patients. It cannot be used in CKD patients. And in certain patients with HLA 5801 positivity, they have a high chance of developing Steven-Johnson syndrome. So they have a high chance of developing Steven-Johnson syndrome. So you have to remember this genetic association, that prior to starting of allopurinol, you have to do HLA 5801 levels, right? Now, other drug that you can use is febuxostat. So, other drug that you can use is febuxostat. It can be used in CKD patients, and it can be used in patients who have HLA 5801 positive, right? So, this is the advantage that you get out of febuxostat. So, if you are asked preventive treatment of choice in a patient who is having chronic kidney disease, your answer would be febuxostat. If you are asked most common drug that is given as a preventive treatment for gout, answer is allopurinol. If you are asked that a patient who was given allopurinol developed a skin rash, right? Which is the genetic association seen? There would be HLA 580. So a patient who has developed a rash to allopurinol, which drug will you give? Answer is febuxostat. So these are the important MCQs that can be asked from you. Now uricosuric drugs. Uricosuric drugs are probenecid. They are not used much nowadays. Now we come to something known as uricase. So what are uricase? Uricase basically convert uric acid to a more soluble product known as allantoin. So their role is to convert uric acid into a more soluble product that is known as allantoin. So what are the drugs that we have? We have rasburicase and pegloticase. We have rasburicase and we have pegloticase. Some important points that you need to remember here. These drugs are given by parenteral route. These drugs are given by parenteral route. And rasburicase is the drug of choice in tumor lysis syndrome. It is the drug of choice in tumor lysis syndrome. So, this is all about the preventive treatment of gout. Okay. Now, let's read some important differences between gout and pseudo gout. So, gout is basically due to the deposition of monosodium urate. Pseudo gout is due to the deposition of calcium pyrophosphate. Okay. Monosodium urate is the most common joint to involve is the metatarsophalangeal joint. give rise to podagra. In pseudo gout, the most common joint to be involved is knee. The most common joint to be involved is knee. Podagra is rarely to never seen in calcium pyrophosphate disease. So podagra is basically is not seen in calcium pyrophosphate disease, but it is a characteristic of gout. Okay, they give rise to negative birefringence, and pseudo gout you see positive birefringence. Okay, so these are the three important differences between gout and pseudo gout. Next, if you look into the imaging, as I said that the most common joint to be involved in calcium pyrophosphate disease is knee. So you get this imaging finding known as chondrocalcinosis. So you get this important imaging finding known as chondrocalcinosis. Okay. Next, another image based question that can be asked. This is known as Milwaukee shoulder. This is known as Milwaukee shoulder. Seen in elderly. It is seen in elderly and it is a destructive arthropathy. It is a destructive arthropathy of shoulder joint. It is a destructive arthropathy of shoulder joint, and you will be asked which crystal is responsible for it. Answer is calcium apatite. Calcium apatite crystal is responsible for a condition known as Milwaukee shoulder. Right? Then, as you can see that you have a pyramidal or bipyramidal shaped crystals. You have a bipyramidal shaped crystals in your synovial fluid analysis. The synovial fluid analysis. So these are basically the calcium oxalate crystals. These are the calcium oxalate crystals. All right. So we basically come to the end of this module on crystal induced arthropathies. So let's summarize what we have read here. So they form the most common cause of episodic arthritis, right? Too many attacks of acute arthritis can give rise to chronic arthritis. In gout, you have the deposition of monosodium urate, which gives rise to negative birefringence. In pseudo gout, you have deposition of calcium pyrophosphate, which shows positive birefringence. You get chondrocalcinosis in pseudo gout, and you get erosions with overhanging edges in gout. Never give preventive therapy in acute gout. Never give preventive therapy in acute gout. And serum urate levels can be normal in patients of acute gout. Can be normal in patients of acute gout. So this basically brings us to the end of the module on gout and crystal arthropathy. Thank you.